this computer. All right, so for today, we're going to just kind of be going over some general information as far as disease process manifestations, like for example, cystic fibrosis. If you get a question about cystic fibrosis, understand that is a congenital defect. When people think about it, they think about the lungs. And yes, absolutely. Primary involvement with cystic fibrosis is in the lungs, and it causes the patient to make copious amounts of tenacious sputum. It is thick, hard, and they can't expectorate it. That's one of the biggest problems with cystic fibrosis. Intervention for those copious, tenacious sputum events are chest physiotherapy. So if you get asked about chest physiotherapy, remember cupped hands that are basically kind of tapping different areas of the lung fields on the patient's anterior and posterior. And you intermittently would stop, reposition the patient, get them to take a deep breath, cough. What you're doing is you're trying to break up that thick sputum and help them be able to expectorate it. And then the other thing to keep in mind is that cystic fibrosis also affects the pancreas and the digestive tract. And the pancreas is responsible for two enzymes, lipase and amylase, and that's from the exocrine perspective, right? We're not talking about endocrine and insulin, but it affects the production, cystic fibrosis does, of the pancreatic amylase and lipase. And remember, amylase you need to break down starches and metabolize them, and lipase you need for lipids, fats. So these patients will commonly have steatorrhea, right? In other words, they'll have diarrhea that is fatty, right? It floats in the water on the toilet, right? What we will give them is something called pancrease or pancreolipase. These are capsules with a man-made pancreatic enzyme. And so that's the one time that you would break open the capsule and you would sprinkle the contents on each of the patient's meals, okay? That's cystic fibrosis. Commonly, those are the questions that you're going to get, something to do with either pancreatic enzymes or, chest physiotherapy. Let's talk about other birth defects, the trisomies, and particularly Down syndrome. So just remember, with any of the trisomies, it's when the fetus, or actually the embryo, is developing, you have 23 sets of chromosomes, right? Your DNA, mommy's 23 and daddy's 23 and me, for a total of 46. The 23rd set are the sex chromosomes. So that determines, are you a female? Are you, XX or XY? But the other 22 sets, during development, things can go wrong. And so with 21, trisomy 21 at the 21st level, that's Down syndrome. And with Down syndrome, there are characteristics, physical manifestations that make the babies with Down syndrome identifiable. Remember this, the board's been liking to ask this question about creases on the hands, right? We all have 3 palmar creases. So there are 3 creases on your hands. We all have them. Down syndrome, they will have 1. Typically, could be both hands, could be one hand, but at least one of those hands is going to have 1 palmar crease instead of 3. That's like a screaming sign of Down syndrome. Let's see, when we talk about other birth defects, remember, you will get asked questions about some of the reflexes that are supposed to be present at birth. So remember, the Moreau or startle reflex, that's the one where as you're lowering the infant, and this is the fun one, the baby goes, arms go back, mouth opens. It's a reflex like that like, I'm falling, right? Normal, expected reflex in a newborn, up through 6 months of age, 5 or 6 months of age, right? The Babinski reflex, that's the one where on the baby's sole of his foot, you take your finger or a pen light or whatever, and you stroke from the heel and then up towards the medial aspect. In other words, like if this were the great toe, up towards the great toe. And as you do that, the baby's toes will fan out, right? That's a normal expected reflex. The Babinski reflex, again, up through about 6 months of age. Anything after that, there's a problem, right? The Babinski reflex is typically gone once a baby starts to either like rock and crawl, right? Once they start having their own motion. A Babinski reflex in anything other than a newborn is an indicator of traumatic brain injury. It's very bad. And while we're talking about neurological things, make sure you remember posturing, neurological posturing. So in other words, there are positions that people will get into involuntarily that are indicative of a brain injury. And the two that you really need to know are decorticate and decerebrate. And I will actually pull up a cheat sheet and show that to everybody. Well, you know what? I'm just going to pull it up online right now to show you, but I do have a cheat sheet for it. And the way to remember which one is worse, decorticate or decerebrate, is easy. When you think of decerebrate, think of chopping off somebody's head. Decerebrate, I've chopped off your head, right? Versus decorticate, there's a problem for sure, right? When you look at this picture, decorticate, they look like they're praying. Their hands are usually with flexed, at their chest. Their feet are pronated inward and toes pointed. And again, that's bad. Don't get me wrong, traumatic brain injury, but decerebrate is the worst one. Their arms are flexed out at their sides, right? Arms are straight, they're extended, their hands are curled, usually. That is a bad sign. They're probably not going to make it. Okay, they're probably not going to make it. So just remember that if you get a question on the boards about that, it may be like, is this decorticate or is this decerebrate? It's not going to be a complex question, okay? So that's posturing, neurological posturing. When it comes to diagnostics, we'll talk about infants and then we'll talk about adults. Just remember, got to know your Apgar scoring. Okay, so the Apgar scoring, that is test that's done at 1 minute after birth, and then again, a second test at 5 minutes after birth. So it's done twice. We give that baby 2 opportunities to get a good score. And your maximum score is a 10. And what we're looking at is facial expression, cry, color, movement, right? And we're scoring appropriately. So, anything that's 7, 8, 9, 10, good. If the baby's score is below a 7, a 6 or lower, you have some concerns. And I'm talking about, their first or second score. Because basically, if the score is below a 6, are they not crying at all? Are they blue versus having any kind of a pink color? So it can dictate problems maybe that baby has. And don't forget about during labor, fetal heart rate monitoring. And just remember veal chop, right? So veal chop, V-E-A-L. If you have variable decelerations, which means the baby's heart rate is dropping just willy-nilly, not even related to the mom's contraction, that's bad, right? Placental insufficiency. If you have early decelerations or late decelerations, they're bad too. Early means the baby's heart rate is going down at the beginning of a contraction. Late decelerations, the baby's heart rate's dropping at the end of the contraction. With all of those 3, interventions are typically left lateral recumbent position, get mom on her left side, administer oxygen immediately, and especially with late decelerations, that can be a sign of a nuchal cord. So in other words, the umbilical cord is wrapped around the baby's neck, which can mean that they need an emergency C-section, okay? But with all 3 of those, the priority intervention right off the bat is left side for the mom, oxygen, and then, did it get better? Did it get worse? Are we giving her a C-section? That's important to know. The A in veal chop means acceleration. If the baby's heart rate goes up, that's good. I mean, that's fine. That's what we want, right? So that's a normal and expected response. If you're squeezing me and I'm like, whoa, and my heart rate goes up, that's good. If you're squeezing me and I'm like, my heart rate goes down, that's bad. So just keep that in mind with those. Any questions about fetal heart rate monitoring? Okay. When we talk about other neuro issues, and I really don't think I gave you guys enough as far as neuro, so that's why I'm kind of concentrating on that. Let's talk about meningitis. And so spinal meningitis, inflammation of an infection of the meninges, which are the coverings around the spinal column and the brain. Can be viral, can be bacterial, but presents the same nuchal rigidity, right? So in other words, the neck is very stiff. They can't do this or this because it hurts. And we'll talk about the Kernig's and Brudzinski sign. And photophobia, not photosensitivity, photophobia, where the light literally is painful. It hurts their eyes, okay? And then it will present also, the third thing would be either a severe headache or a fever. You know, they don't have to have a fever, but if a patient presents with nuchal rigidity and photophobia and they have a headache, they probably have spinal meningitis. And how do we diagnose it? Lumbar puncture. Okay, so to definitively diagnose meningitis, what we're going to do is we're going to do what's also known in the lay world as a spinal tap. So we're going to get a needle. The anesthesiologist will usually perform this, sometimes the doctor. Get the patient in either a tripod position. Tripod is where the patient is literally leaning over a table or a chair. Or if they're in a bed, we get them in a lateral recumbent position, like a fetal position. Because when they're curled, it opens up the space between the vertebrae and makes it easier to get the needle into the spinal column to draw out CSF, cerebrospinal fluid, right? And what we're looking at is we're looking for turbidity. In other words, is it cloudy? Because it shouldn't be cloudy, it should be clear. And then we're also looking under the microscope, do we see bacteria? So is it bacterial, right? So that is the one way to diagnose meningitis. And there is a meningococcal meningitis vaccine, conjugated vaccine, that they're recommending that patients get, or that people get, I should say, around the ages of 16 to 18 to prevent them from getting meningitis, okay? I'm going to take a 1 second break because let me just pause this and let somebody else in. Okay, so to finish talking about lumbar puncture. So one of the most common issues post-procedurally is what they call spinal headache. So it's important that after a lumbar puncture, patient needs to lie supine, don't move for at least 4 hours, right? Because there's a displacement of cerebrospinal fluid. And, you know, if they move, they will get the worst headache that anyone has ever had in their life. And it's a very difficult one to treat. So post lumbar puncture, stay supine, 4 hours, don't move, prevent the spinal headache. And then the other potential complication is throwing a blood clot. And there's a twofold reason. One is because they're laying supine and not moving for 4 hours. So you want to make sure that you have either sequential compression devices on their lower extremities to keep the blood return going, right? Or prophylactically, possibly, you know, like an antiplatelet or something, or at least anti-embolism stockings, right? And then the other reason is just because of the needle itself. So most common complication of a lumbar puncture, spinal headache from them moving too quickly, or throwing a DVT, okay? And that's it for that. What other diagnostic tests? Let's see. When we talk about, you know, reflexes, just remember, you know, with reflexes, you may or may not get asked a question, and it probably will be in relationship to the administration of, say, mag sulfate for somebody with preeclampsia or eclampsia. When they are sluggish, so when reflexes become sluggish or, God forbid, absent, then you know that they need calcium gluconate, and that's the antidote for that. Okay. When it comes to Herbals. I've also been hearing a lot of people that have been taking their boards say that they've gotten a lot more questions on different types of herbals. Just remember, herbals are usually plants, right? And so keeping that in mind, there are some kind of commonalities that you can figure out. So for example, chamomile, right, which is to calm you down. They make a chamomile tea, okay? So chamomile is made from the chamomile plant. If you have seasonal allergies, you might not be able to tolerate chamomile. Think about it. It might elicit this like an allergic response, like a hay fever. Echinacea. Echinacea is that other one. It's made from a plant, right? And it's used to, they say, boost immune response, right? So echinacea also made from a plant. So certainly it can elicit this hay fever response. Don't forget that. And then I think I talked about it last week, but I'll just say it one more time. When people are on any kind of pharmaceutical meds, especially antiplatelet or anticoagulant, there's so many herbals that don't jive. And remember the ones that start with G, they never go with an anticoagulant. So ginkgo, ginger, ginseng, and I can't even remember the last one, but so they're the ones that are problematic. Garlic is the last one that can actually cause excessive bleeding. Okay, so remember that. Remember with seizure activity, if somebody's having a seizure, you, in this order, if they're in the bed, get them on the floor, right? Protect the head, blanket, pillow, jacket, shirt, something under their head. Loosen any clothing that's tight around the neck. Time the seizure. Seizures that last 5 minutes or more, problematic. They can cause brain damage. The only drug that can stop a seizure is a benzodiazepine, usually Valium, which is diazepam, but also Ativan, lorazepam can work. Okay, that's for seizure activity. And then don't confuse that with anticonvulsant medications. Make sure you remember your phenytoin and your carbamazepine. Okay, they are the two old school anti-seizure meds that the board likes to ask about. And with both of those, you're going to be doing serum drug levels for both of them. Carbamazepine is the oddball. It's 5 to 10 serum level, therapeutic serum level, 5 to 10 for carbamazepine. Let's see. And a patient can become toxic with either phenytoin or carbamazepine, just like they can with DIG or theophylline or any of them. And by the way, don't forget theophylline, respiratory drug, and that therapeutic drug level is 10 to 20. Okay. Okay. Let's see. We talked about seizures, brain injury. Remember that for chronic neuralgic pain, nerve pain, right? Example, post-herpetic neuralgia, which is pain after the shingles, right? So herpes zoster can cause pain at the site wherever it was for the rest of the patient's life, even once the shingles are resolved and healed. It will always hurt because they've attached to a nerve, right? They're not just superficial on the skin. And so, believe it or not, for post-herpetic neuralgia, amitriptyline, which is an antidepressant, tricyclic antidepressant, widely used for nerve pain, amitriptyline. Okay, so that is becoming more and more the drug of choice for post-herpetic neuralgia. And carbamazepine, that anti-seizure drug, ATI has a crystal ball because there was a question about trigeminal neuralgia and the use of carbamazepine, an off-label use. It's the boards too. So make sure you know this. For trigeminal neuralgia, which is nerve pain that involves 3 sets of nerves, the cranial nerves, right? Up around the face, mouth, neck, head, okay? One of the more common modalities of treatment now is carbamazepine. Anti-seizure drug, but it works great for trigeminal neuralgia, okay? Make sure you remember your Glasgow Coma scale, right? Your maximum score there is 15. You're measuring or you're assessing a person's level of consciousness. So you're assessing their eye response, You're assessing their speech, right? So in other words, if you go into a room and you say, Miss Mary, and I'm like, hey, what's up, right? I'm a 15, my eyes open, I can respond, right? So make sure you give a quick review to the Glasgow Coma scale, because, if they tell you, you're caring for a patient, their Glasgow Coma scale is a 5, the patient's probably obtunded, right? The word obtunded, that's another one that I don't think I use enough with you guys. It's not quite comatose, but very, very minimally, if any, responsive, right? So they need painful stimuli for them to respond, if at all, okay? So Glasgow Coma scale for level of consciousness. Talked about neurological posturing, meningitis. All right, so for neuro, really, I think that's about it. For endocrine, please don't forget your insulins. You will have a question about an insulin. I don't know which one, right? Or metformin. And with metformin, I'll just remind you guys one more time, any procedure with contrast dye, angiogram, angiography, CT scan with contrast, IVP, intravenous pyelogram for the kidneys, all of those use contrast dye. The patient's on metformin, they can't have it the day of and 2 days after the procedure, or we'll put them into renal failure. Okay. Other tests, cardiac enzymes. And this is another one that I don't think we go over enough. So when it comes to labs, just remember, cardiac enzymes, CKMB, right, or troponin. There are others, but they're the two big ones. Cardiac enzymes are enzymes that get released when there is significant damage to muscle tissue. So if a person's having a heart attack, there's a predictability about these enzymes in the blood. In other words, at the onset of the heart attack, a myocardial infarction, the heart muscle, the myocardium, stimulates the release of these enzymes into the bloodstream. So they'll always do 3 lab draws, 3 sets of cardiac enzymes when the patient goes to the ER with symptoms that look like an MI. 3 sets. Why? Because cardiac enzymes will be at a certain point, and then 6, 8, 12 hours later, they will elevate and peak. And then, whether it's troponin or CKMB, 6 to 12 hours afterwards, they'll start to decline, right? Which is a classic symptom of confirmation, right, that the patient probably had an MI. Now, the enzymes can elevate for other reasons. Rhabdomyolysis would cause an increase in CKMB and troponin, believe it or not, because that's muscle tissue that's deteriorating, right? A cardiac contusion. If somebody's in a really bad traumatic accident with impact, if they have impact, say the airbag in the car explodes, hits them in the chest, cardiac contusion, damage to the muscle, not an MI, but still the cardiac enzymes will increase. Okay. Don't forget your BNP, brain natriuretic peptide. That is a blood test that we do, and it gives us an indicator about fluid retention. Normal should be under 100. Okay. Anything greater than 100, they're retaining fluid. Okay. I'm glad we earlier had done some questions. So remember, tuberculosis, signs of active tuberculosis are unintentional weight loss, night sweats, chronic cough, may or may not be accompanied by pink, frothy, like bloody sputum. Okay, that is a sign of active tuberculosis. Don't forget the test for tuberculosis, the PPD, which is the purified protein derivative test, where they do an intradermal bleb and assess it 48 to 72 hours later. You're feeling for an induration, 10 millimeters or more would be a positive. If the person's immunocompromised, 5 millimeters or more. So a person with HIV is more likely to contract TB. That's why the standard for a positive is lower than for your general population. And once a positive PPD, you never have another. That's it, because it will always come up positive. Okay. And then, of course, don't forget airborne, right? MTV, that's measles, tuberculosis, varicella. They like to ask about donning and doffing personal protective equipment too. Just remember, when you are removing personal protective equipment, the dirtiest thing comes off first. So the gloves are always the first thing that you remove. And oh, by the way, if you are in a room with a patient on any transmission-based precaution, you are supposed to remove your PPE at the doorway before you exit the room so that you're not dragging whatever they have out into the hallway. Right? Makes sense? Okay. Also, another thing that I don't know that I mention enough is when you are removing linen, right, or whatever, clothing, linen from a patient's room, you never hold linen against your body. Kind of makes common sense, but still sometimes, so let me just put it out there, okay? It should always be bagged in the room and then taken out, right? So if you see people grabbing, the dirty linen up off the floor and carrying it down the hallway, like that's a no-no, don't do that. Okay, it should be bagged in the room and then removed. That's the right way. Remember with delegation, since we're talking about, those things too within hospitals, the aide can do anything that is a task-oriented assignment. Just make sure that you're taking into consideration the aide's experience, their job description, right? Their level of training and education. So in other words, are they able to perform that task? Is the patient that you're giving them stable? That's important. You would never give an aide an unstable patient. And don't read your questions too quickly because sometimes they'll ask about RN delegation to LPN. Right? When it comes to LPNs, a lot of misconceptions out there about scope of practice. Understand that typically the Board of Nursing is very loosey-goosey about scope of practice. Okay, and I think I put it up. If I didn't, I will put it up today. The Nurse Practice Act for the state of New Jersey, which are the regulations, what you can and can't do as a nurse practitioner, an RN, LPN, and an aide. Okay, it's not very specific. Generally speaking, they don't want nurses, LPNs, or RNs doing IV push medications. Okay, but LPNs can start an IV, a peripheral line. They can manage an IV as long as they've been trained, right? As long as they've had the training to do it, they can do it. It's not outside their scope. There's very little outside the scope of an LPN. So unless it's a facility-based protocol that they have. So in other words, if somebody tells you, oh, LPNs can't do wound vacs, well, maybe not in that facility. There is nothing written anywhere that precludes an LPN from managing a wound vac, as long as that LPN has had the training for that wound vac. Okay, so remember that. And with oversight, there's pretty much, LPNs can't do dialysis independently, but LPNs are dialysis nurses because there are RNs available to oversee it. Same thing with head to toe admission assessments, right? Not an LPN thing, but you do them all the time because there's an RN available for oversight. Okay. Care plans, the RN is supposed to be the one that initiates the care plan. The LPN can add to it or reinforce the education. Aides can't teach. Remember, don't delegate whatever you can eat, evaluate, assess, teach, or treat. Right. So just remember that when you're reading questions. TPN, total parenteral nutrition. In the real world, you can manage it with RN oversight, but if the board asks about it and somebody tries to assign an LPN, a TPN patient, you would contact your charge nurse or the unit manager, right, to have an RN oversee the TPN. It's a lot of N's, right? And with total parenteral nutrition, the biggest concern are blood sugars. So just remember that one line. If you ever get a question about TPN, total parenteral nutrition, we're giving you everything you need nutritionally through an IV. So we're bypassing your entire digestive tract, right? Everything's going through the IV into a vein. And the biggest issue is when they start ramping up the TPN, blood sugars can start to go haywire. So hyperglycemia can be a very bad complication of a patient receiving TPN. If the patient's on TPN, you better be doing finger sticks, and they should be getting done at least 4 times a day. Okay, just remember that. Trying to think of anything else. Diabetes insipidus, the water deprivation test. Remember, diabetes insipidus, waterfall. So, you know, the patient that's just urinating constantly, whether they drink or not, you may get a question about the water deprivation test. Remember, if diabetes insipidus is waterfall, syndrome of inappropriate antidiuretic hormone is the opposite. That patient will have retention, generalized edema. They will just not pee. And that's an easy treatment for SIADH, diuretics. Got to make them pee. And for diabetes insipidus, because of the antidiuretic hormone that they lack, right, or that they you know, don't have, we give them vasopressin, or it's also called desmopressin. So if that's a question, desmopressin, vasopressin is a treatment for diabetes insipidus. It's a man-made antidiuretic hormone, okay? So it will stop them from peeing out their brains. If you get a question about Cushing's or Addison's disease, remember, both of them have to do with steroid, either your own steroid, which is cortisol, or with Cushing's disease, if I am giving you medication that is a corticosteroid for the long term, I can actually give you Cushing's syndrome, because Cushing's means too much corticosteroid in the body. And just remember, with Cushing's, they're cushy. It's the way I remember it. Moon face, fat pads on the neck, buffalo hump, pendulous abdomen, truncal obesity, little skinny arms and legs, striae on the abdomen, stretch marks. They will have imbalances like hyperglycemia, okay, but they will have hypokalemia, okay. They are also at risk for fractures because of osteoporosis, because of calcium deficiencies. Whereas with Addison's, it's just the opposite. They're super skinny, right? They don't have enough cortisol, so they're super skinny. They have too much potassium, hyperkalemia, but hypoglycemia. All right, so it's just the opposite, Addison's and Cushing's. And then one more thing with Addison's, they have a bronzed tone to their skin. Okay, that's indicative of Addison's disease. If you get any questions about thyroid, just remember, when it comes to thyroid function, your thyroid controls your metabolism. If the thyroid is hyperactive, then everything's high and fast. If the thyroid's hypoactive, everything's low and slow. And when we're looking at labs, when we're assessing thyroid function, the TSH is the opposite of what your thyroid is doing. So if your thyroid's hyperactive, your TSH is low. If your thyroid is hypoactive, your TSH is high. But your T3 and T4, thyroxine, that will be doing exactly what your thyroid's doing. Hyperactive thyroid, T3, T4 are up, but TSH is down. Hypoactive thyroid, T3 and T4 are low, but TSH is up. And the medications that are used, the only meds you need to know about, levothyroxine for hypothyroidism, methimazole and propylthiouracil for hyperthyroidism. And with those 3 medications, the biggest issue is dosing the patient correctly, because the risk for complication is always incorrect dosing, and I send the patient in the other direction too far. Too much levothyroxine, and now instead of being hypo, now I've made you hyper, right? You get the point. And with levothyroxine, that medication needs to be taken in the morning by itself, full glass of water, and the patient should not have anything, no meds, no food, nothing else, at least 1 to 2 hours after taking levothyroxine. And while we're on the topic about what time you take a med, remember, the patient's on a statin, they should be taking it at bedtime. If they're on montelukast, they should be taking it at bedtime. If they're on a long-acting insulin, they're probably taking that at bedtime, okay? Remember those things. If the patient's on an inhaler, And they have two, one's long acting, one's short acting. Short acting first, open things up, then the long acting, so it works better, right? Alendronate for osteoporosis. That's another one. That drug, when it's given orally, it should be taken by itself, full glass of water, and the patient needs to stay upright for at least 30 minutes after taking it. They should not lie down. They should not be eating, drinking, or taking other meds. Alendronate can cause erosive esophagitis. So it can actually kind of erode or eat away the lining of the esophagus. So that's one of those meds. By itself, full glass of water, stay upright for 30 minutes. Okay. Stress test, EKG stress test. Just remember, with a stress test, you're going to tell the patient to wear comfortable clothing because they're going to be getting on a treadmill if they can tolerate it, right? There are, medication-induced stress tests. So there's an adenosine stress test, okay? In other words, if the patient has arthritis and they can't get on a treadmill and walk or run, jog, then we can give them an IV medication to simulate that, make their heart rate go up, and then watch their EKG and look for changes. Okay. Sometimes people with cardiac issues can have a normal EKG when they're just sitting there. But when the heart is under stress, it starts to beat faster. Then that's when we see EKG changes. That's why stress tests are necessary. Remember, with cardiac cath, you're going to ask your patient if they're allergic to iodine or shellfish because we use contrast dye. Remember that after the procedure, the patient that's the other instance where the patient can't move. They're going to lie flat for at least 4 to 6 hours, supine, with a pressure dressing at the catheter entry site, as well as usually a sandbag or two over to prevent hemorrhaging. Okay. Remember, when it comes to EKGs, and this is where I'm going to kind of wrap things up. When it comes to EKGs, just understand basics. When you look at an EKG, just at a glance, you should have a P wave, a QRS, and a T. That's lub-dub, okay? And they should be spaced evenly apart. If they're all scrunched real close together, that's tachycardia. If they're way far apart, that's bradycardia. And when you look at them and you can't see a P wave, a QRS, and a T every single time, that means something's wrong, okay? If you see a bunch of sawtooth, beep, 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 and then a QRS and a beep, 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 QRS, that's atrial flutter, right? If you just see, you can't see P's, Q's, R's, S's, nothing, that's usually VTAC, ventricular tachycardia. Check for a pulse. You're going to defibrillate. Okay, it's usually a pulseless rhythm. If you see a little and nothing else, it's usually ventricular fibrillation. They're going to die. You don't even have to check for a pulse. I can tell you they don't have one. Defib. Ba-boom. Okay? And when it comes to medications, if they're real close together and there's fast heartbeat, metoprolol, you're going to think beta blockers, calcium channel blockers, because they slow the heart rate down, right? If it's super slow, you're going to think atropine or adenosine because they speed the heart rate up. Okay. Was that enough for one day? It was enough for me. So I'm going to call this quits with the recording. If you have questions, you know where to find me. So I'm going to tell you good skill as always.